என்ன பண்ற நீ? ஃபர்ஸ்ட் ஸ்லைட்ல ஏன் வைக்கல? ஃபர்ஸ்ட் தான் சார். எதுக்கு புரியல? ஏன் மகன் மழை தானே இருந்தது, எதுக்கு நீ மாத்தின? இல்ல சார், அது உடுப்பா, வேண்டாம்ப்பா, எதுப்பா ஃபர்ஸ்ட் லைடு விடு, அது வேண்டாம். எதுக்கு அது? யாரும் ஒருத்தர் Ankana?
Sir, just give me a minute, sir.
No problem. No, I'm online. I just wanted to make sure.
Yeah.
I wait for you.
Sir, we are already live, so with all your due permission, I am beginning with the session for today. Good afternoon, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor present here with us today. Well, he is none other than the very renowned ophthalmologist, Professor Dr. Mohan Ranjan, sir. Sir is MBBS, DNB in Ophthalmology, DO, FMRF, MNA-MS, MCH, FACS, DD, FIAMS, FRCS, PhD, Diploma in Science Chairman and MD of Rajan Eye Care Hospital, Chennai. With Sir's wonderful experience and his valuable insights, we are going to talk about the topic for today, which is recent advancements in ophthalmology. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you, Ankana, and let me thank the IJCP for this wonderful opportunity. First of all, I have to apologize for the delay because I lost one of my gurus, my teachers this morning, so I had to go for the funeral. That's the reason for the delay. I have a very strong association, Dr. K.K. Agarwal, and I really miss him a lot. He is really a visionary. And today I'm going to talk to you about recent advances in ophthalmology. As you know, every 5 seconds, one person in our world goes blind, and a child goes blind every minute. Are you able to hear me? Are you able to hear me? Hello? Are you able to hear me? The global blindness.
Yes, sir, I can hear you. Continue.
Fine.
Yeah.
So the economic, why do you need to bother about the blindness? Because the average number of working years lost due to adult blindness is about 10 years. The average age of the blind children is about 8 years, loss of 33 working years. If you look at the global blindness, it's increasing year after year. But what is more important for all of us is that 1/5 of the world blindness is in India. So India, at any point of time, there are about 20 million blind people, and there are about 25 million people who are visually impaired. So which comes to almost 45 to 50 million people, which is a huge number. And if you see the eye works like a camera, the analog camera, where an object in front of the eye goes, get reflected or refracted through the cornea and the lens to the retina, to the back of the eye. From the retina, it goes to the optic nerve, to the visual system. So there is a basic difference between optician, optometrist, and ophthalmologist. The optician is one who dispenses the glasses. The optometrist is one who checks the power of the glasses. Ophthalmologist is the one who checks the complete, what you call, the health of the eye from A to Z. If you see a normal eye, the light rays go through the clear cornea and the lens and get reflected onto the retina. And if a patient has the corneal opacity means the cornea becomes white. The cornea becomes white, the patient is not able to see, and this is called the corneal blindness. And these patients benefit by corneal transplant surgery. If you have a patient with dense cataract, which occurs usually in older people, wherein the lens in the eye, the crystalline lens, which is normally transparent, becomes opaque, and that blocks the light, and that's what we do the cataract surgery for, and implant a lens, which is called intraocular lens, and the patient regains surgery. The field of ophthalmology has made rapid strides in the past 20 years, especially in lasers and cataract surgery. If you take the curable blindness spectrum, like cataract, corneal opacity, short sight, long sight, ocular trauma, diabetic retinopathy, glaucoma, wherein the eye pressure goes up. So all these can be almost completely reversible, and these constitute almost about 75 to 80% of the cause of blindness. And if we take the cataract, any point of time, there are about 12 to 20 million people. 5 million is added every year. 60% of blindness is between 30 and 64 years. This is the immature cataract, and this is a mature cataract, which is a very common scenario in a country like India. So we have the 1990s, we had the advent of small incision, micro incision cataract surgery, wherein there's a faster rehabilitation, faster recovery, and lesser astigmatism. This is the advent of topical anesthesia, wherein we just put drops and remove the cataract and put a foldable lens. That is called the no injection, no stitch, no pad cataract surgery. This is Asia's first mini keyhole cataract surgery, which was installed in our hospital way back in 2005. And this is one of the main advances in the cataract surgery. As you see here, the cataract which was now earlier removed with a very large incision, being removed with a very small incision, as small as about 2 millimeter or even 1.8 millimeter. And the whole cataract is being what you call cut and sucked by this machine called the phacoemulsification, which is nothing but an ultrasonic machine. Once you remove the cataract, you can see that cataract is a white mature cataract here. And once you remove the cataract, then go ahead and put a lens, which is called a foldable lens. You can see here the lens goes in and folds in the eye. This foldable lenses, the recent advances, a lot of advances. For example, we are putting only before about 20, 30 years back, only unifocal lenses. But nowadays, we have what is called multifocal lenses, extended depth of lens for lenses. This is a multifocal lens you can see here, wherein the patient is able to see without glasses, distance, intermediate, reading, everything without glasses. So the patient is able to, after the cataract surgery, the patient is able to see, become young, see young, think young, and also look young. And also, that is the advantage, and that is a huge lifestyle change as far as the cataract surgery is concerned. One of the recent advances in cataract surgery is what we are doing, what is called the robotic cataract surgery, which is called the catalyst. The advantage of robotic cataract surgery is that the regular cataract surgery we do with the hand, which is called the manual. The robotic cataract surgery we do with the computer. Because of the computer usage, the safety, precision, speed, accuracy, and also it's a bladeless technology. The robotic system, which is there, which was installed in our hospital about 6 years back, and we have done the highest number till now. Why? Because robotic is, as you know, artificial intelligence is making a big this thing in healthcare, especially in the field of ophthalmology. You can see diabetic retinopathy and glaucoma. We're able to use AI to detect glaucoma and diabetic retinopathy. Can a computer perform better than the human brain? Definitely yes, because these are the different, what you call the femtocataract systems which are available. This is called the Catalyst, this is the LensX, and this is the Victus, this is the Lens AR, and all these systems are also there. So the biggest advantage you can see here, this patient, the way robotic cataract surgery is being done, the patient is taken into the theater and the robotic operation theater, and you can see here, once the eye is docked and the surgery does all the machine does all the work by cutting the cataract and doing what is called the capsular access. And this is a vacuum, this thing which we do. This is one of the latest in the cataract surgery, which is making cataract surgery almost like an outpatient procedure, wherein the patient can walk in, walk out, and resume their normal activities and get their vision close to when they are young. So the manual phaco is similar to what we are using. It's a Sachin Tendulkar, who was good in one format of the game, whereas the FLACS, that is the femto-assisted cataract surgery, or the femto-laser-assisted cataract surgery, similar to Dhoni, wherein is versatile in all formats of the game. So that is the biggest advantage of the robotic cataract surgery, which you are doing very commonly. You can see this is a robotic cataract surgery, a patient who's got a very dense cataract, and you can see that the robotic cataract surgery, wherein the cataract is able to, the laser is able to cut the cataract into smaller pieces, and that is the biggest advantage of this robotic cataract surgery. Again, we have what is called the Zepto laser, which is again a nitinol ring which we introduce into the eye and produce opening on the surface of the anterior capsule, which is called the Zepto laser. And that is one of the biggest advantages. Now, people who cannot afford the femto laser, we use zepto laser as well, which is again a recent advance. Again, in the field of IOLs, you can see that a lot of advances are there. Before we used to use only unifocal. Nowadays, we have enhanced unifocal lenses, or even the EDOF lenses, or the VVT lenses, Symphony lenses, or the trifocals like Panoptics or Synergy, or Acrylis or Optiflex Trio, wherein the patient is able to get good vision, good quality of vision, independent of the glasses as well. And these are the different lenses which are available in the market, which are available to everybody here. What is the future IOL? The future IOL is going to be something like this, wherein the data, whatever data which is there in the Google, will be incorporated in the IOL. So the IOL will probably give you an idea of what is the weather condition today and what is the Google Maps and everything. And that is what we are looking at in future. And because the technology is incorporated and getting incorporated, and because the engineering is getting into the medical science, and that is one of the biggest advantages of this. And this is also another thing wherein you can see here the future IOLs, wherein you can see that I'm using a very simple method of removing the cataract in the right eye with the slit lamp, slit lamp mode. So the cataract removal has become easy, effective, and enjoyable. And we have the advantage of also a new technique, which is called the 3D surgery. This 3D surgery, what is the thing is, we use the 3D glasses. Just like a laparoscopic surgery, we do the cataract surgery, the retinal surgery, and the glaucoma surgery, everything. The advantage is that this is the RTO system, which have been recently installed in our hospital. The advantage of the 3D surgery is that because the resolution is better, the magnification is better, the depth perception is better, and also the ergonomics for the surgeon is better. You can see this is the advantage of 3D surgery, wherein I use the 3D goggles and look at the monitor, and instead of looking into the microscope, and it's no more a microsurgery, it's also all 3D surgery, it's heads-up surgery. I don't have to look into the microscope and going ahead with the cataract surgery. And even if the difficult of the cataract is able to do that, because we are combining the technology with the technique, which is again very, very important. The RTO 800 3D surgery is one of its kind, which is making our life easy, and not only for cataract surgery, but also for retinal surgery as well. Again, you can see here, the depth perception is simply amazing, it's incredible, and the patient satisfaction is also very high. The surgeon is also very comfortable, and we can do a lot of surgeries. One of the recent advances in the 3D surgeries. Again, the refractive errors, the long sight and short sight, is one of the major problems in our country, wherein patients are using the short sight glasses. The short sight means it's called myopia. The long sight is called the hypermetropia or the plus power. And we have the conventional LASIK laser, the femto LASIK, the blade LASIK, and then we have the femto LASIK laser. But nowadays we have what is called the smile laser. The smile is nothing but what you call the small incision lenticular extraction. This is again a new addition. It's the latest in technology. The advantage of this machine is that because of by putting a small incision, we are able to extract a lenticule from the cornea, and because of that, we are able to reduce the myopia as well as the astigmatism, the cylindrical power as well. So just to show you the animation here, how a smile laser works. You can see here how the smile laser works, and going ahead and putting that this thing here, and the femtosecond laser is able to go through the cornea and create a small lenticule there. Once you create a small lenticule, it is all precise. It is all up to the micro level or the microns. So it's a lenticule. The lenticule is only about maybe around 50 to 100 microns, or even less than that. The thickness of the cornea itself is about 500 microns or 540 microns. You can see the once that this thing is there, all this is done through a small incision. That's why it's called a small. Patients who got very high myopia, more than -8 or -9 or -10, we can't do the smile laser or the LASIK laser. So we don't send these patients off, because these patients have got a huge social stigma as well. So we need to take care. And this is called the phakic IOL, where you can see here, a phakic IOL means an IOL which is very thin lens, just like a what you call contact lens it is, and it is much thinner than a contact lens. And this is the ICL lens, which is being star ICL lens, which is being implanted. This lens goes in front of the natural lens, which is called the natural crystalline lens. And because of that, we can treat patients even up to the power of 25 or even 30 with this technology, starting from -9 or -10 and going up to 25, 30. And the patients, because of that, is able to see better. This is a corneal collagen cross-linking, which is again a new technique wherein patients who have got keratoconus, wherein the cornea becomes a little irregular because of constant rubbing or constant allergy in the eye, and this keratoconus, wherein the cylindrical power can go up. The corneal collagen cross-linking, wherein we put riboflavin drops and then use ultraviolet light. Glaucoma is again a very major issue. Many people are having glaucoma. Glaucoma, there are two types. 60 million people are blind worldwide. And in India, about 7.5 million people are blind due to glaucoma. You can see this is a normal optic disc. This is the glaucomatous optic disc. And what happens is in glaucomatous, there are two types of glaucoma. There is the open angle glaucoma, which reduces the side vision, that is the field of vision, and the angle closure glaucoma, wherein a narrow angle glaucoma, wherein the pressure can go up all of a sudden. So we have different methods, different types of laser. This is an automated perimetry wherein we check the field of vision. You can see how the early glaucoma, how the field of vision is going off in the left side. On the right side, bottom slide, you can see a patient with advanced glaucoma will have only something like a tunnel vision. And that is the problem with the glaucoma. So we need to find out thing. We do what is called a ND-YAG laser. There are 6 or 7 different types of laser we use in ophthalmology for different conditions like glaucoma, retina, the green laser for retina, the yellow laser for retina, the YAG laser for glaucoma and after cataract. Again, there are a lot of advances in eye drops, lasers, and surgery. Surgery in the form of trabeculectomy or even tubes and valves we are putting. Diabetic retinopathy is becoming a very huge problem. 101 million people are suffering from diabetes in India, which means that 20% of these diabetics will develop a condition called diabetic retinopathy, and 25 times greater risk of going blind compared to the general population. We have different stages of diabetic retinopathy, background, and the 4 stages of diabetic retinopathy. But what is important for all of us is that we need to find out prevention is better than cure, find out much earlier, because if the patient goes into very advanced stages of diabetic retinopathy, they can have a problem of retinal detachment and decrease in the vision because of the hemorrhage inside the eye, like what you see in the slide. And because of this, you can see this is an advanced diabetic eye disease, stage 4, wherein the retina gets detached. It's called the tractional retinal detachment, which again can cause a huge problem, and we do a surgery called vitrectomy for these patients. Again, the different types of laser, as I told you, the laser photocoagulation, we used to use the argon laser photocoagulation and the diode laser, but nowadays we are using the green laser and the yellow laser for the diabetic retinopathy, wherein the laser photocoagulation, and then we have a lot of injections called anti-VEGF injections, vascular endothelial growth factors. This is the digital fundus fluorescent angiography, or the fundus or the retinal camera, wherein we give a dye and take serial photographs of the retina. This is again optical coherence tomography, which is nothing like something like a CT scan, wherein it takes a biopsy, something like a biopsy of the retina within a few seconds or 1 minute, without even touching the eye, and all non-touch technique. And patient undergoing yellow laser for the retinal problems, or this is the advantage of the diabetic retinopathy, wherein different types of laser is being used. Again, advances of diabetic retinopathy, we have what is called the sutureless vitrectomy. But of course, we are now having a lot of advances in this artificial retina. This artificial retina is something which is a lot of research is going on in the US as well as in the UK, wherein a high resolution electrode array is placed on the inward facing the surface of the retina in close proximity to the retinal ganglion cells. And this can also work like the eye works like a camera. Of course, gene therapy is being done in many hospitals, especially in the UK, Moorfields Eye Hospital. They are doing gene therapy. Only thing is it's very costly for our Indian conditions. The advantage of gene therapy is that it can take care of the patients who have got hereditary retinal conditions like Leber's, or patients who got night blindness. We call it retinitis pigmentosa. And these are these things. Again, we're using artificial intelligence in a very big way in diagnosing diabetic retinopathy and glaucoma. The advantage of the glaucoma, the artificial intelligence there, you can see that these artificial intelligence wherein this is a AI enabled fundus camera wherein we go to the what you call the periphery or the slums and we check the blood sugar, check the BP, and then take the photograph of the retina. Once we take the photograph of the retina, then what we use an AI app you can see here, and we can see the AI app to find out. Even offline we can do. They can see the AI app wherein artificial intelligence app we can find out whether this patient has got a diabetic retinopathy, whether this patient has got a normal retina or an abnormal retina, normal optic nerve or an abnormal optic nerve. So in which case, artificial intelligence is able to, because of this, we're able to screen a huge number of people. And we're using these technicians and also skilled assistants for this. This AI-enabled fundus camera, which is being used now in Rajanai Care, and we're using it in a lot of slums as well. Of course, the biome, the advanced vitreoretinal surgery, wherein it is all sutureless. Just like cataract surgery, this is also a sutureless vitrectomy surgery. We're going through a very small gauge into the eye. And this we used to do that with 20 gauge, but nowadays we are doing that 23 gauge, 25 gauge, and even 27 gauge vitrectomy, wherein very small incisions are made into the eye and go in and remove the bleeding from inside the eye. And if the retina detachment is there, we settle the retina and then put silicone oil, and patients are able to see much better after the surgery as well. So, hello?
Yes, sir. Hello, am I audible?
So, what happened? Yeah. Is it? We have some more time?
Yes, we do have, sir. You can continue.
No, I don't know what happened.
Sir, your screen got stopped sharing, so you have to share it again. Yeah.
1 minute. Share the screen again. What happened? Yeah. What was that? Yeah. I'm sorry about it. No. Screen sharing the mail இருக்குங்களா? சைடுல கிளிக் பண்ணணும். இருக்கு. Able to see now? Sorry.
Yes, sir.
Sorry. Diabetic retinopathy treatment, we have injections, anti-VEGF. Anti-VEGF, there is a new kind of injections wherein we give injections into the eye, which works straight on the retina, and even steroid injections, lasers, as I told you, surgery, which is a minimal invasive vitreous surgery, which is again very, very important for us. Macular degeneration is another huge problem wherein the center of the retina gets affected. People are living longer, and because of that, they're able to get this macular degeneration. A normal person, how the vision will be there, and the patient who's got macular degeneration, where the central vision, because the center of the retina is affected. And this is a wet macular degeneration. We have different tests for this. And the dry type of AMD, wet type of AMD, wherein the wet AMD we use different types of injections into the eye, as I told you, anti-VEGF injections, which is called Lucentis or Avastin or Razubam or Eylea, or even what you call the Peganax, which is there. So different types of injections are there, different types of laser we are used to do, but nowadays we are doing only this thing. And for dry AMD, we give a lot of antioxidants and zinc, and which will take care of this thing. This is called the AREDS formula, wherein we get a combination of the vitamin A, C, E, lutein, and zeaxanthin, which is again. Of course, patients who got advanced macular degeneration, we have different types of low vision aids. which will magnify the images for them, and so that they're able to see the near vision. This we are doing before that, the photodynamic therapy, which is again a different type of laser for wet macular degeneration. Nowadays, we are not doing this much, but this is again different types of anti-VEGFs which are available here, which are using regularly for this macular degeneration. Eye injuries, 90% of the injuries are preventable, 40 to 45% are again domestic. These are some of the pressure cooker injuries. This just to show you a patient which is the largest at that time in 2007-8, when wherein the patient has a drumstick inside the eye, drumstick went inside the eye. These patients used to be given up. And nowadays, we are able to remove these intraocular foreign bodies because of the advanced, sophisticated technology and techniques which are available with us. And this patient is able to now, it's almost 12-year follow-up now, more than 12-year follow-up, and the patient is having around 70-75% vision. You can see that. So that is the advantage of the technology which is available. Corneal blindness is again a very huge problem. 1.5 million people are blind in our both eyes. One person's donation can give sight to 2 people. The cornea is only transplanted, not the whole eye. And this is a corneal opacity. Can you see here? When the cornea undergoes an insult or infection, the cornea loses the transparency and becomes white. This is called the corneal opacity and blocks the light, as I told you in the beginning. And this is called the corneal blindness. We have approximately about 1.52 million people, and majority of them are children less than 15 years old. So these patients require corneal transplant surgery. This is a full thickness corneal transplant surgery, where you can see here the entire cornea, the deceased cornea, the white cornea is removed and replaced with the cornea taken from the dead person. So this is the corneal blindness, which is again which we are doing in our eye bank regularly. And this corneal blindness is one of the major issues in our country now, affecting mainly the children. And that's the reason why India is the largest producer of childhood blindness in the world. And because of the corneal blindness is one of the major issues, mainly because of trauma and because of vitamin A deficiency, which was there before, but nowadays it's not there. But because of trauma and infections in the eye. So this is the corneal transplant surgery. This is again a lamellar keratoplasty, which is again wherein we have the recent technique, the recent advances is that the cornea has got 5 layers, and whichever layer is defective or diseased, that layer alone we replace. The 4th and 5th layer we replace. This is called the DSEC surgery or the DMEC surgery, deep stromal endothelial keratoplasty or deep lamellar endothelial keratoplasty, and that is one of the biggest advantages. And because of that, because we are not replacing the entire cornea, the rejection is also very less, and the results are much better. Patients who have got problem in the first three layers of the cornea, sometimes the patient who got keratoconus, where the cornea becomes abdominally thin, then we do a surgery called the DALC. You can see the preoperative picture, the postoperative picture, how the vision is improved in these patients after DALC also. So the DALC surgery and the DSEC, the DMEC surgery has changed the whole ball game as far as the corneal transplant surgery is concerned. So this is to show you the corneal transplant, already showing you how the preoperative results when the cornea is white. After the cornea transplant, how the cornea has completely become transparent and the patient is able to see well. Give the gift of eyes, donate eyes, do not burn them, do not bury them. There is life after death. And artificial cornea is coming into a big way. There are a lot of research going on in India, in Germany, in the US as well, wherein the artificial cornea, wherein this artificial cornea is implanted into the cornea, and that takes care of the front of the eye as well as the back of the cornea as well. And this is going to be one of the important thing, and a lot of studies going on in L.V. Prasad Eye Institute, wherein 3D cornea is also available. Of course, stem cells, just like any other part of the body, the human stem cells from a wide variety of sources being used to explore eye disease, transplantation therapies, especially for corneal conditions, and even for retinal conditions, and sometimes even for the optic nerve conditions. So all these are in the pipeline, but it will take a long time for this thing. Of course, we have a lot of other community service projects. We also have what is called the Netra Vahana. This is Netra Vahana is the tele-ophthalmology van. You can see this van is equipped with all the different types of lasers, and wherein the van goes to the periphery, taking tertiary eye care to the rural doorstep. So eye care tips for eye care: vitamin A rich diet, regular annual checkup of eyes with the ophthalmologist, children of parents with eye problem to be checked early, good control of your diabetes, hypertension, the patients with family history of glaucoma, retinal detachment to have a regular checkup. Even if they don't have any problem with the vision, they have to come for a checkup on a regular basis. Early referral again for patients who got diabetes and good control of diabetes, good control of blood pressure, good control of kidney functions, no smoking, no taking alcohol, good emphasis on regular follow-up with the treating ophthalmologist and also diabetes. Thank you very much, IJCP, for the wonderful opportunity. This is just to give you a spectrum of what all is happening in ophthalmology in the past so many years. Of course, it's a never-ending thing which is called ongoing research, ongoing journey, which is going on forever, which is making everybody making sure that we are a blind-free India very soon. It will take about a few years or maybe 10 years or 20 years from now. But what is important for all of us is that there are approximately about 35 or 40,000 ophthalmologists across the country. And we are able to get all this technology, access to the technology. And we are making quality eye care available, accessible, affordable to one and all, irrespective of caste, creed, religion, and socioeconomic status. And we're able to get the technology to what was available in the US and the UK and Western countries here at a much 1/10 or 1/5 of the price. And that is the biggest advantage. I'll stop sharing the screen. Once again, I would thank IJCP for a wonderful opportunity. And again, I would like to apologize for that, my delay.
Thank you so much, sir. Thank you for such wonderful insights shared by you. And we are extremely sorry for the loss that we have heard today. Extremely sorry. And our condolences to you and to his family as well.
Yes. The person whom we lost is none other than Dr. Badrinath, the chairman of Shankar Netralaya, where we all got trained. And he is a person who actually brought the retinal surgery into our country way back in the 70s. When he was from the US, he came back from the thing, and he was the one who started the whole concept of the vitrectomy retinal surgery, what I was talking about in patients with retinal detachment and diabetic retinopathy. And he was the person who was responsible for that. He's a trendsetter, he's a game changer, and he has trained so many. And this Shankar Netral is one of the biggest institutions. And he's been there, and he's like a colossus for all of us. And we have lost him today. And it's a big loss for the entire nation, I would say. He's also a Padma Bhushan, and he has been honored by the President of India twice. That is Padma Shri as well as Padma Bhushan, and a great visionary par excellence. Thank you very much.
Rightly said, sir. Thank you. I mean, thank you for taking out your valuable time and for being here. Of course, we can understand the grief that you are going through, and we're extremely sorry for that. But on the other hand, like it is said, the show must go on. So yes, we are continuing with our day-to-day course, and we are here for that only. So moving on to the question answers round. So if you permit, then shall we take few questions that we have received?
Yeah.
Okay. So
sure,
the first question that we have received is, how have recent advancements in glaucoma management impacted the approach to diagnosis and treatment?
See, the glaucoma is a condition wherein it's like a thief at night. Okay. So before we used to have patients coming very late to us in the advanced stage of glaucoma. The biggest problem of glaucoma is that whatever field of vision, whatever damage is already done, we cannot reverse it. But nowadays, we are able to pick up glaucoma much earlier because the awareness among the patients are much better. And we also have the technology. For example, the OCT technology, I told, the optical coherence tomography, and also the automated field analyzer. So all these are able to pick up the glaucoma much earlier than normal. And also we are using this artificial intelligence for glaucoma also. The AI is able to pick up, the AI is able to screen a lot of patients. Suppose we are able to manually screen only about 100 patients, the AI is able to screen about 1,000 patients at the same time. So the advantage of AI is that, and because of that, you're using that for glaucoma. As a patient, because the patients are coming in early, the treatment modality is also much better, so more effective. So, and also, even for patients who are coming a little late, before, for glaucoma, we never used to have any proper treatment. Nowadays, we've got fantastic eye drops. We can reduce the eye pressure, keep the glaucoma a good check. We've got fantastic lasers. We have the, what you call the laser, as I told you. We have also the SLT, which I forgot to mention, the SLT, the selective laser trabeculoplasty, which is again another different type of laser, which we can do. All these are outpatient procedure, non-invasive. We just have, it takes only a few minutes, and we're able to reduce the pressure and prevent further damage in glaucoma. So glaucoma is a huge problem in our country, and we are facing that. It's like a glaucoma epidemic, which is there, and also the myopia epidemic is also there, especially after COVID.
Thank you so much, sir. Thank you for answering that question. Like you mentioned about the artificial intelligence, we have received another question related to that. And the question is, how is artificial intelligence being integrated into ophthalmic diagnostics, and what impact has it shown in improving accuracy and efficiency?
Yeah, absolutely. It's a beautiful question, actually, because artificial intelligence is coming in a very big way. Okay, not only in ophthalmology, but also in healthcare, in other specialties as well. So one of the biggest advantages of artificial intelligence is that it is able to, because we don't require, because it's very difficult for an ophthalmologist to go every nook and corner of the country. So because ophthalmologists are only approximately about 40,000 ophthalmologists, and ophthalmologists are all busy with doing surgeries and taking care of the tertiary care, curative aspect. Now we need somebody like screening to do, and the screening can be done by optometrists. And these optometrists are trained to a certain extent, but even by skilled technicians, they can go and screen. So we have what is called mobile fundus cameras, which are AI enabled, because there is only an app. Before, the mobile fundus cameras have to be connected to a internet line for us to find out whether this patient has got an abnormal glaucoma or abnormal retinopathy or something like that. But the artificial intelligence, even offline, because there is an AI app in all these cameras, mobile cameras now, and these cameras, you don't have to even dilate the pupil. It's called non-mydriatic fundus cameras, wherein without dilatation we can take a photograph of the optic nerve and the retina, the center of the retina, which is the center of the retina is important for diabetic retinopathy. The optic nerve is important for glaucoma. So the AI will be able to find out whether this patient has got abnormal or normal. Okay, if it's abnormal, the patient is referred to us. So suppose we screen 1,000 patients, okay, and 1,000 patients, about 990 patients will be normal. 10 patients or 20 patients or 30 patients will be abnormal. So these 30 patients alone we need to see. The remaining patients we don't have to see. So we don't have to waste time, because the patients can be screened late, can be asked to come after a year or 2 years or something like that. But these 30 patients, we know these are our patients who are at high risk. So the artificial intelligence plays a big role there, where they come into play there, because they're able to, even with the technicians who have passed 10th or 11th or 12th standard, trained technicians, they're able to take a camera. We have got vision centers in the periphery, the rural areas. The vision centers are all manned by optometrists, and these vision centers are even opticians for that matter. And they take the cameras, and automatically they find out whether using the AI app, they are able to find out whether the patient has got glaucoma or diabetic retinopathy. If there is a suspicion, they refer the patient to the base hospital. So the AI is going to play a very major role. So many people say, no, AI is going to make people lose jobs. I don't think so. The AI becomes supplemental in whatever you are doing. So the AI is going to, for example, now, and there's a nice project which is being done by Shankar Nethralaya, Nara Nethralaya, RP Center, along with the Google, Sundar Pichai, they are doing it, wherein the caliber of the retinal vessels they're using the AI to find out whether this patient has got likelihood of getting a heart attack or cardiovascular disease. So all these are there, because the retinal vessels are the only vessels which you can see in the entire body. All other blood vessels you cannot see, but the retina vessels you can see with the use of a fundus camera or use of a what you call a lens. So you're able to see the retinal vessels. By gauging the retinal vessels, we will have an idea of how his heart vessels will be, how his brain vessels will be, how his kidney vessels will be. And this artificial intelligence comes into play there and finds out whether this patient's got high risk or low risk.
Thank you so much, sir. Thank you for answering that question in so much details and explaining our viewer about the advantage of artificial intelligence and the healthcare system that has been incorporated. Moving to the next question that we have received, sir, and the question is, What are the challenges and considerations when managing eye conditions in the pediatric population?
Yeah, the pediatric population, one of the biggest challenges is that because the pediatric eye is not like a miniature adult eye. So everybody should know the pediatric eye is a totally a different ball game. So we need to have specialized pediatric ophthalmologists who are trained in pediatric ophthalmology, and they can take care of the pediatric eyes because these eyes behaves totally differently, and everybody thinks it's a miniature adult eye. It's not like that because the pediatric eye has got different problems, different things. For example, the biggest challenge we are facing in our country is, of course, we have a huge problem of the childhood blindness. The main problem is the corneal opacity, as I told you, in children, and also congenital cataracts, congenital glaucoma, and also a problem of what you call the squint, the lazy eye. We call it amblyopia in medical terms. So all these are problems are there because the major problem, especially when you go to the rural areas, the consanguineous marriage is there. The people getting married within relation. And because of getting married within relation, for example, they're marrying their own cousins or their own uncle or something like that. It's very common, especially in South Tamil Nadu and South India for that matter. I'm sure it is common common also in the other parts of the country as well. And because of that, the children who are born to these parents who are married within the family, they are likely to get not only problems, congenital means since birth, congenital means since birth, and the congenital problems in the eye, but also congenital problems in other parts of the body. For example, they can have congenital heart defects, and they can have congenital kidney defects. They can have congenital problems in the brain, and problems in the bones also. So all these factors can come, and this is one of the major issues which you are facing in childhood blindness in our country, and that's the reason why we have the highest number of children with blindness. Of course, we are eradicating that to a great extent, and because we are using the technology, we are also screening. We are having special screening camps for the children. We are also doing what is called school vision screening. The school vision screening, which we are doing, not only we are doing, but also ophthalmologists across the country are doing school vision screening, wherein the children are screened not only from the date of their birth, but also from the time they start going to school, which is about 2.5 years. They start going to school now. We check the vision 2.5, 3 years. And not only that, every year we check these patients for, check these children for this thing. So the ongoing school vision screening program, which is helping us to detect many of these congenital problems like congenital cataract, glaucoma, and squint, the refractive errors, short sight, long sight, myopia is becoming a very huge problem in children because children are all now using a lot of gadgets and phones, iPads, tabs, and especially after COVID, and they're all likely to get myopia. The incidence of short sight myopia, which was about before the COVID, it was around 15%. It has become 24% now, which is that. So 1 in 4 children in India are now wearing glasses, which is a huge problem we are facing in our country. And because of that, we need to have to change the lifestyle. We have to tell the children this thing, and that's the biggest problem we are facing now as far as the myopia epidemic is concerned. So because of that, we have to screen the children. We have got special drops, and we are also stipulating now how much of screen time each child should have, how much of external activity, because the external outside sports activity, exposure to sunlight is also very important, which many children are not doing now. So blindness in children is becoming a huge factor, but we have got the wherewithal to take care of it.
Thank you so much, sir. Thank you for answering that question. And without taking much time of yours, we will move to the next question and the last question for today's session. And
Yes.
the question is, what progress has been made in the application of stem cell therapy for ocular diseases, and what are the potential future implications?
The stem cells are becoming a very major role, especially for chemical injuries, the acid alkali injuries, wherein the ocular surface is completely screwed up, and the stem cells are becoming a very major thing, wherein the stem cells are first used, and the surface that regularizes the surface, and then we go ahead and do what you call a corneal transplant, and we do what is called even a keratoprosthesis, the osteoodontokeratoprosthesis, wherein we take the teeth and put it in the eye, or we do what is called the Boston keratoprosthesis, wherein we take an artificial cornea and the keratoprosthesis. The stem cells are becoming a very major thing, and even for retinal problems, hereditary retinal problems, the stem cells are being used, and this is going to play a very major role. There are two things which are going to play a major role. One is the stem cell, and another is the gene therapy. As far as the eye, gene therapy mainly for the retinal conditions, and stem cells mainly for the problems in the front of the eye, that is the cornea. And these are the two main therapeutic interventions, which are likely to increase in the future, in the years to come. And of course, artificial intelligence, as I told you, as far as the diagnostics are concerned. The therapeutic is concerned, we have got all the therapeutic now, all the drugs available now, but something like stem cell gene therapy, which is going to add on to our armamentarium.
Thank you so much, sir. Thank you for answering that question for all our viewers. And thank you for taking out your valuable time in spite of today's day. So I'm extremely respectful and sorry, and thankful to you, sir, for taking out your valuable time and for being here for all our viewers, and for sharing such wonderful insights with the videos that you have shared, and by putting across such beautiful presentation to us. And with this and with all your last take-home message, sir, we would like to conclude the session here for today. Until next time.
Thank you. Once again, I would like to thank IJCP for this wonderful opportunity. And I really miss Dr. K.K. Agarwal. He is really a great man, a man with a vision. And he is the one who actually was responsible, especially during the COVID time. He did really a fantastic job, and really miss him forever. And the take-home message for all the people. Hello, you're able to hear me?
Yes, sir, you are audible.
Hello?
You're audible, sir.
Yeah. Take-home message for all people who are listening, and that eyes are the gift of sight, is the gift given to God, given to mankind by God. So it is your responsibility as well as our responsibility to preserve it forever. So it is prevention is always better than cure. So even if you don't have a problem in the eye, please go to an ophthalmologist and regularly check your eyes. Just stay there for 1 hour or 2 hours or whatever it is, dilate and have a look at your retina, your optic nerve, your eye pressures on a regular basis. Don't go to an optician or an optometrist, because an optician will just dispense the glasses. An optometrist will just check the power of your glasses. So there can be a problem of glaucoma, there can be a problem of cataract, there can be a problem of cornea, there can be a problem of the optic nerve and the retina. Unless you go to an ophthalmologist, there are a lot of very, very competent ophthalmologists across the country. And if you go to an ophthalmologist, they will do an A to Z check of the eye, because the technology, as I told you, is available across the country. And we are proud, India is to be proud of the fact that every nook and corner of India, we have the best of the technology, especially in the field of ophthalmology. So that is making the quality eye care available and accessible and affordable to all one and all.
Thank you so much, sir.
Yeah, thank you very much. Thank you very much.
Yeah, thank you so much. With this, we are concluding the session here for today. Until next time.
Thanks a lot. I'm leaving the session. Thank you.
Yes, sir. Thank you, sir.